started here. We are, and my name is Kat. We will be talking here. Thank you for joining us. Thank you for joining us for mental health concerns counselors should be aware of when working with women experiencing infertility. We have with us today Corina Harris and Dr. Kelly. I'm gonna botch it.
Forzia Fitel, that's fine.
Forzia Fitel. We have a Q&A you can add to, and there's going to be discussion points throughout. So our two co-presenters are going to kind of take things over, but if you have anything you want to add, just go ahead and add it to the chat, and I'm going to hand it over to our presenters.
Okay, well, thank you, Kat. Like Kat mentioned, thank you all for attending our presentation today. We're going to be talking about the mental health concerns counselors should be aware of when working with women experiencing infertility. Like we mentioned, there's the chat option. There's going to be discussion points throughout the presentation, so feel free to come off mute and contribute or use the chat, and we'll have a part at the end where we answer questions. And also, sorry, I live by a busy road, so if you hear cars, I tried to limit that as much as I could, but I'm Corina Harris. I recently graduated from the Commonwealth University of Pennsylvania Lock Haven campus, formerly known as Lock Haven University. I have a master's degree in clinical mental health counseling, and I currently work as an outpatient clinician at a local to me group private practice, and I'm from close to the Lock Haven area in Pennsylvania, and I'm currently pursuing licensure to become an LPC in Pennsylvania. And my research interests really are infertility and women's health and anxiety disorders. So I'll turn it over to Dr. Pytel for her introduction.
And Michelle, I see you're in Pittsburgh, not too far away from both of us. So I'm actually, I'm Kelly Pytel. I'm in Williamsport, Pennsylvania right now. I hold a PhD in counselor education and supervision from the Pennsylvania State University, and I currently work as an assistant professor at the Commonwealth University of Pennsylvania Lock Haven. We just merged and we just changed our name, and it's very long. My specialty areas consist of military, trauma, grief, and loss and their impacts on individuals, families, and the communities. And I've grown to have a more recent interest and finding ways to better to support women who are at various stages of pregnancy. So we're excited to be here today, and thank you for joining us.
Some of the learning objectives we're going to talk about today is to understand the prevalence of infertility and the associated definitions. We'll examine the types of infertility treatments and associated costs to provide context for contributing factors. We'll discuss the reported mental health concerns experienced by women affected by infertility. And then we will look at the context for counseling strategies to implement with women experiencing infertility.
But before we get started, we want to know what brings you to this presentation. So this will help us adapt our presentation a little bit based on our audience. And so feel free, like we said before, to share verbally or to use the chat. What brings you to this presentation?
I see there's some people in our waiting room too.
Let's see.
I let them in.
Okay, thank you.
Thank you.
You're welcome. Give them a minute. Those who are joining us, sorry about the wait. We'll welcome you to our presentation of
We may have lost Kat. I think you muted yourself.
I'm sorry, my bad. So this is health concerns that counselors should be aware of for women who are experiencing infertility. We have Karina Harris and Dr. Kelly. I already forgot how to pronounce it.
And that's fine. Thank you for the introduction again, Kat. We thank you all for joining us. I see that Sierra had answered our question, but for those who just joined us, we really want to know what brings you to this presentation. So why are you interested in the mental health concerns of women experiencing infertility? And Sierra, thank you for posting in the chat. Interested in working in women's health, had a baby at 25 weeks and realized there's a lack of support for women in the hospital. Thank you for sharing that. Anyone else want to share why they're in this presentation? As a counselor experiencing infertility myself, I recognize the need to learn more and figure out ways to monitor boundaries and self-care for those types of considerations. And then currently have a few women in private practice that are struggling with changing medications while pregnant. Community health and working with women's health program for self-pay, slide, Medicaid clients that need access to mental health services related to women's issues. So thank you. There's quite a wide range of some coming in with personal experience, some coming from the counselor perspective of maybe better understanding how to work with women who are pregnant. I think I'll speak for myself, realizing that there is a need, kind of going back to what Sierra said, to be able to better to support women at the various stages of trying for a baby, getting pregnant, having the baby. When you are pregnant, there's a lot of, I don't want to say a lot of support, but you do regularly check in with doctors. But then after you have the baby, that support really slows down. And so we're really thinking of this as a different lens. We're looking at how do we help support women who are experiencing infertility. So there's a really long journey that potentially comes with infertility. And we'd love to better educate you today in our session about what that looks like and our roles and how we can better support as counselors. So thank you all for sharing. And we do hope that you chime in with your experiences, the lens that you're taking to help us with.
I'm sorry.
Go ahead, Kat.
I'm sorry. My autistic son came in and I was unmuted. I'm sorry.
Oh, that's okay, Kat.
Okay, so we're going to look at the prevalence and definitions of infertility to get a better understanding of what it is, the types of it, and how often it occurs. And so the World Health Organization defines infertility as the inability to conceive or achieve pregnancy through unprotected sexual intercourse after 12 months. So a woman has been trying to conceive and it's taken 12 months, and that's when they define somebody as being infertile. Now, this presentation is going to focus solely on women. There's definitely some work that could be done on couples or male infertility, but for the purposes of this presentation, we're going to focus primarily on women. What some people don't realize too is that there's types of infertility. There's primary infertility and secondary infertility. Primary infertility is where a woman has had no prior births, no prior children, and is unable to conceive. Whereas secondary infertility, these women have had prior children, and now they're struggling to achieve pregnancy again to have more children. And what we've learned through doing this research is there's really a lack of research. Even though the prevalence of infertility is 1 in 5 women in the United States between the ages of 15 and 49. That's how often we're seeing infertility in these women. And so 1 in 5 women, that's quite a bit. And if you think, if you're a practicing clinician and the amount of people that you see in a day, it's likely that you're going to encounter a woman experiencing infertility. And yet there's really just a lack of research of how we can work with women experiencing infertility. There's also several physical health conditions that can contribute to infertility. So we know that, and to be able to achieve pregnancy, a woman needs to have a good working system, right? So they need to be able to have a menstrual cycle and achieve ovulation to conceive. Women who experience infertility typically will have physical health conditions that impact the functioning of their reproductive organs, the completion of a menstrual cycle, and achieving ovulation. Now, this is not an encompassing list of all the possible physical health conditions that could occur, but some of the most common physical health conditions that contribute to infertility are polycystic ovarian syndrome, or what's referred to as PCOS, diminished ovarian reserve, poor operation of pituitary glands, impaired functioning of the hypothalamus, and premature ovarian insufficiency or menopause. The uterus itself may also contain structural abnormalities that contribute to infertility, like adhesions, inherited irregularities, or polyps. Some other issues that could come up would be endometriosis, infections, ovulation issues, problems in the menstrual cycle, implantation failure, or autoimmune disorders. So there's quite a bit that could be going on in these women's bodies that are going to contribute to infertility. There's also several risk factors. So smoking, alcohol use, weight gain or weight loss, obesity or low weight, emotional or physical stress, which we'll talk more about throughout this presentation, but it's important to recognize the emotional and physical stress that could be happening, sexually transmitted diseases, and the age of a woman. So we all have heard that saying, like, my clock is ticking, or your clock is ticking. And in a sense, that is true. And that the research shows that fertility decreases with age and can start declining when a woman reaches only 30 years of age, which to me is incredibly young, but only 30 years of age. And it continues to decline significantly after 40 years of age. So all of these things can be a combination of these things or one singular thing that really causes infertility and prevent women from achieving pregnancy. Next slide, please. So now that we know what infertility is, how it's defined, and some of the factors that can lead to infertility, let's look at how it's treated and how much it costs. So if a woman is unable to menstruate or achieve ovulation, part of the treatment could be that they're prescribed ovulation-inducing medications. And as we said before, a woman must ovulate to be able to conceive a child. So when she's unable to, that's when these medications are coming in. Some of the most commonly known are Clomid, which usually comes in a pill form. There's injections that can be prescribed to these women. One of them is Gonal F. And then there's also other shots that are in the fertility world called trigger shots, which then promote ovulation in the body. So there's a lot of different medications, and they're all very individualized to the woman's fertility journey. These pharmaceutical treatments are then coupled with either IUIs or intrauterine insemination, assistive reproductive technology or ARTs, or timed intercourse. Now, I didn't put timed intercourse on this slide because it's not really a treatment. It's something that the couple would do if the couple is coming for infertility. And that is just that the intercourse is timed precisely with the woman's cycle. Now, IUIs, and it's important to know the acronyms for these, because in the fertility community, if you're talking with a woman, they may say, I have PCOS and I needed to do an IUI. And if we don't really learn that verbiage, then it can often lead to people just kind of feeling misunderstood, that there's a lot of jargon that goes throughout these treatments. So an IUI, or an intrauterine insemination, is less invasive, and it can be done in a clinical setting like an OBGYN office. The ARTs, or the assistive reproductive technologies, they're more invasive, and they require more procedures, more monitoring by the physicians, and they need to be done in a different setting. So you can do them in fertility clinics or hospitals. And one of the most known is in vitro fertilization, or IVF. There's others that are there listed on the slide, but that's what I have come into contact with women that I've talked to that are experiencing infertility. IVF is one of the more well-known. And again, they're very individualized. So this is going to be prescribed by the doctor and the fertility clinic, and it's all based on what the woman's fertility journey really is. Now, when conception is not attained through an IUI or an ART or timed intercourse, there are alternatives for these women, and that can be third-party reproduction. That involves the use of a donor for the egg, the sperm, or the embryo, or it can be completed with a gestational carrier or a surrogate. So also, to pause here for a moment, keep in mind that these medications can impact the hormonal production in a woman's body, which may impact their mood. And we'll talk about that a little bit more throughout the presentation, but just kind of keeping in mind what implications this may have for counselors or mental health professionals, especially when we're diagnosing. So we need to keep in mind how these things are going to be impacting this woman's body. And now the big one, let's look at the cost. So one study that we looked at examined the cost of these fertility medications. And I put IVF on there just because it's more well known by people when we talk about infertility. So the study that we looked at, they looked at the average cost of medications, and they totaled about $1,200 per month. That's without insurance coverage. I'll talk about the insurance coverage in just a moment, but without insurance coverage, these women could be paying upwards of $1,200 per month on just the medications. Now, if they need to couple that with one of those assistive reproductive technology or the ARTs, they're looking at maybe around $24,000 to $38,000 per cycle. And when I say per cycle, that means per month, right? Our menstrual cycles happen per month. And that's what these cycles are, per month. So that's an exorbitant amount of money that these women are then having to pay, or these couples are going to have to pay for these treatments. So then I got curious of what my own insurance coverage would cover, because there's often little to no insurance coverage for these treatments. And just mine alone, my personal one, and we could examine all different types of insurance coverage, but there's so many out there. So looking at mine in particular, I found that my insurance would only cover 6 ovulation-inducing medications per lifetime. So that would give me 6 tries to conceive. And that's, in the scheme of things, not really a whole lot of tries. And it would also cover 6 IUI treatments per lifetime, but it would not include any other procedures. So no IVF, none of these assistive reproductive technology procedures, none of those would be covered. What I also found was this money would have to be paid up front, and then I would be reimbursed. So I would have to have an extra $1,200 in my accounts. And depending on where the cycle fell with the longer months, you may be paying that twice initially in a month. So that money would have to be paid up front. I'd have to have that in my account, and then it would be reimbursed. So take a moment and really just think about your own accounts, and you don't have to share any of that. Please don't share your personal things there, but think about the money that you would have to have up front to be able to pay for those things. And really, could you? That's a lot of money. And so what does that mean for us as counselors too? And I wanted to make this point here of, we would have to then consider how much money our clients are paying out per month. And if they're seeing us as providers, for any of you who are providers in the mental health field, we'd have to consider how much money they're putting out per month, and then also what they're paying us. So do we need to do a sliding scale? Do we need to change the cost of their treatment so that our treatment really isn't a barrier to them? At the bottom of the slide, there is a little notation there of selective reduction. We aren't going to talk a whole lot about this in this presentation, but we thought it was important to note that these ovulation-inducing medications, there's a higher risk then to these women of conceiving multiple fetuses because of the impact these medications have on the body. And what they do is they create more follicles. There's more follicle growth, and there's more chances of conceiving multiple fetuses. then these women may be faced with having to terminate one or more of these developing fetuses due to the risk that it poses for multiple pregnancies and for the woman's health and for the developing babies. So this is referred to as selective reduction. And what we found in the research was that these women who then are faced with selective reduction, they can develop symptoms and conditions such as grief, panic disorders, post-traumatic stress disorder, and depression. So we wanted to add that on there just so that you had that for context of kind of, it doesn't, what we said in the beginning, it doesn't really just stop after conception, that there's more things that these women are then facing. Next slide, please. This is an example of what a fertility cycle may look like. Again, this is very individualized, so this is just an example of what one could look like. The menstrual cycle starts day one of this cycle, of this fertility cycle. So a woman starts her menstrual cycle, she calls her doctor, they start ultrasounds. The ultrasounds are completed to really just look at everything going on, making sure follicle size is okay, the ovaries look okay, the lining of the uterus is where it needs to be. And if everything looks good, the physician will then begin medications or injections or both, depending on what this woman's fertility journey looks like. And those medications are done on very specific days of the cycle to promote the best follicle growth. During the medications and injections, during that part of this process, there's a lot of follicle monitoring going on. This means that this woman is going back in for ultrasounds to make sure that the medication is doing what it's intended to do, and that the follicles are growing in the ovaries, the follicles are growing the way that they need to, and that the medications don't need to be adjusted. They aren't getting too large, which can cause serious health concerns for the woman, or just overall, is everything looking okay? Now, these ultrasounds for these follicle monitorings, they can occur weekly, they can occur every few days, sometimes they can occur daily. So that's really doing these doctor visits daily. And we'll talk a little bit more about that when we get to the stress, but think about trying to schedule into your work day in a work week, scheduling in an hour, 2 hours, some 3 hours, depending on where you need to go for these appointments, maybe the whole day, just being able to put that into your day. And so once the follicles are ready, then the type of treatment is administered. So this can be an IUI, ART, timed intercourse, whatever is specific to that woman at that time. And some of these will then need to require the partner to be present if it's a couple coming for the fertility treatments. So that's more scheduling and more arranging of schedules. After all of those steps, so after the weeks of the menstrual cycle, the ultrasounds, medications, monitoring, and the treatment, we go into this 2-week wait period. And that's where conception may be happening. So we're waiting those 2 weeks, and then the woman is told to take a pregnancy test. If the pregnancy test is positive, great, the cycle worked. If it's not positive, the woman will start her menstrual cycle and the whole thing starts over again. So there's no guarantee that any of these medications or any of these treatments are going to work and the cycle starts over again. Next slide, please.
So we wanted to pause here for discussion. Based on what you know, consider the following. How many stores can you walk into without seeing baby supplies? How many people have asked you or you've seen asked, when are you having kids? How many times have you been asked, think medical screeners, if you are pregnant, have ever been pregnant, or have kids? So we'll give you a minute here to think about this. And if you're comfortable, either verbally or in the chat, We want to hear your thoughts.
From every dental appointment they ask. Hannah says constantly.
Almost when you average it out, it could even be more than once a day. You're reminded that of pregnancy and babies,
Mhm.
maybe, probably more than once a day.